Okay, so this is chapter 64 with arthritis and connective tissue issues. And we're going to start with osteoarthritis. So osteoarthritis is not a normal part of aging, but basically what it is it's a wearing down of the synovial joints. It's non-inflammatory, unlike the rheumatoid arthritis. So don't confuse osteoarthritis with rheumatoid arthritis. Um, with osteoarthritis, it's a common form of joint disease. It's a slowly progressive non-inflammatory disorder that affects the synovial joints. The osteoarthritis is, again, not a normal sign of aging, but it is a risk. Aging is a risk factor of osteoarthritis. So aging is not normal, and that was kind of stressed, which is why I'm stressing it. Some of the causes of osteoarthritis are going to be trauma. So let's say you've at some point injured your joint or strained your joint, or you have repetitive trauma, like you repetitively stop or start. Running, soccer, football, things like that, ACL tears. Um, Mechanical stress is that physical sports activity I was just talking about as far as trauma goes. Trauma is uneven stress or of the cartilage. Inflammation, obviously we know that inflammation is the body's reaction to tissue damage, although with rheumatoid arthritis, that's an immune issue. The joint instability, and again, that comes from either being hypermobile or having previous issues, or being some type of uneven stress, traumatic stress. Neurological disorders, so if you no longer have feeling or pain, or you've lost perception, diabetes, for instance, you might cause some synovial joint damage, which will result in osteoarthritis. Skeletal deformities are connective or acquired conditions, dislocation of the hips, cartilage deterioration, things of that nature. Hematologic or endocrine disorders um, are the other contributors. So endocrine issues, you have some type of hormone that's out of whack, and it's created the actual problem itself. And then you have drugs, and again, corticosteroids, which are brought up all the time. Corticosteroids can lead to osteoarthritis or depletion of that synovial joint. The the causes of osteoarthritis are normally known, but it's very complex. And generally you'll see it in the earlier ages. You're going to see it for men, and in the later ages, 50 plus, you're going to see it for women. The causes of osteoarthritis are normally known. We know what they are. It's just a complex system of figuring it out. Obesity, trauma, those sports events that I was talking about, repetitive range of motion, um, and um, although it will be a lack of inflammation. Now, if there is any inflammation in the osteoarthritis, it might be related to tissue damage outside of that. There isn't the systemic manifestations that you see with rheumatoid arthritis. So you're not going to have the fatigue or the fever or organ involvement are not present in the osteoarthritis, and that's present in rheumatoid arthritis, which is one of the ways you can figure out that it's rheumatoid and not osteoarthritis. The pain usually increases with barometric. When the pressure falls, when the environmental pressure falls, it creates more pressure on the joint itself. Barometric pressure, basically when the pressure falls. All right. So morning stiffness is related to osteoarthritis. So getting up and having to spend all that time getting out of bed, that's osteoarthritis. The sitting down becomes more difficult and rising from the chair. So a lot of times elevated chairs or armchairs are easier. Localized pain, stiffness is common. Overactivity can cause disorders, joint fusion, and temporary increased stiffness. Crepitation is a grating sensation caused by loose particles of tartar cartilage. So the cartilage has become less elastic and can no longer support the body the way that it used to. So that crepitation is that grinding sounding, the popping, things of that cracks. That is crepitation that you see with osteoarthritis. Deformities, and a lot of times you'll see this, unfortunately, people start to experience contracture, and you lose range of motion and function. in whatever limited effect. Heberd's nodes, the Heberd's nodes are big nodes that arise. A lot of time you see them in the hands. So when you, I hate to say it, but cracking knuckles, creating a lot of trauma in the joints themselves, and then they become larger. The Broncard's nodes indicate some type of disease involvement of red and swollen and tender, and that has a disease component of it outside of the osteoarthritis. You generally use a CT scan or a bone scan here to detect issues. So here you can use your CT scan to detect issues for your osteoarthritis. Now remember, it's the big difference between osteoarthritis and rheumatoid arthritis is this is not an immune issue. You're not going to see the inflammation. You're not going to see the bilateral injury that you see with rheumatoid arthritis. And again, there's a lot of contraction here. Also, that morning stiffness is a good sign. Now, of course, you can use MRIs. Again, like I said, it can happen in anything, but your cervical vertebrae, hips, your fingers, your feet, and your knees. Care for this. Care for your joints is balance and rest and activity. So you need to make sure that you're actively moving. The affected joint should be rested during any periods of acute inflammation and maintained in a functional position when splints or braces are necessary. Joint stiffness will increase with inactivity. So you can't be inactive for too long with osteoarthritis. The glutamine has been, helpful for a lot of people. Your care for this is going to be, like I said, diagnostic studies of CT, MRIs, and bone scans. MRIs and the bone scans. And we already talked about bone scans in the last video. You can also have nutrition and weight management. So, of course, weight's going to not help your joints at all. So, losing weight and having the proper nutrition, making sure that you're getting what you need. And again, glutamine and chondroitin is a lot of things. One of the things people keep using, hot-cold application. And you have the alternative therapy. So you have acupuncture, meditation, and those outside of the box collaborative care type things. The drug therapy for this is acetaminophen, aka Tylenol, up to 1,000 milligrams every 6 hours. Excuse me, not to exceed 4 grams. So I'm going to write that down because that was hit on before. So 1,000 milligrams, not to exceed 4 grams in a day. Okay. So not to exceed 4 grams, but 1,000 milligrams. Oops, excuse me. 1,000 milligrams every 6 hours. The other thing that you can do, you have opioids, you have NSAIDs, antibiotics, things of that nature, reconstructive joint surgery. Sometimes electrical nerve impulses can be helpful for people. And the glutamine and chondroitin has been proven to actually work, so that's not a bad route to go as far as one of your treatment options, glutamine and chondroitin. Your drug therapies, and again, corticosteroids because it's anti-inflammatory, but like I said, anti-inflammatory, it's going to pinpoint you. There's significant issues with anti-inflammatory, bone loss, things of that nature too. But your inflammation should be seen primarily in rheumatoid arthritis unless there's other structural tissue damage going on. The gold cap compounds, that can also be helpful. The other thing that you can use, like I said, with NSAIDs, and of course you have to be careful with NSAIDs, surgical therapy, we try and manage this conservatively, especially if the patient is older. Arthroscopic surgery or knee surgery might be an option if it's serious. All right. Osteoarthritis, as far as the nurse goes, we are trying to document type and location and frequency, managing practices and questions the patient might have about it. Acute and chronic pain related to physical activity and lack of knowledge of pain management is important. So patient education, of course. And with patient education, we're going to look at maintaining proper weight, using adaptive equipment, avoiding forceful repetition movements. So if they're playing sports, whether they're an avid soccer player or weightlifter, then we should probably talk to them about that. The avoid positions of joint deviation and stress, using good posture, of course, seeking assistance with necessary tasks instead of trying to do it themselves, modifying the home to make it more ergonomic and functional for them. Um, and, and another thing that a lot of people use for this is water therapy or Tai Chi, which has been helpful for a lot of people with osteoarthritis. Um, Now, the rheumatoid arthritis, on the other hand, is a chronic systemic autoimmune disease. It has inflammation properties and uh, inflammation of the connective tissues, right, with the synovial joint. So you might hear diarthrodial or synovial joints. The rheumatoid arthritis, just like your osteoarthritis, it can start off really early, and again, osteoarthritis is not a normal part of aging, whereas rheumatoid arthritis is an immune issue, and that usually happens between 30 and 50 is it, when it comes out. It does have a genetic factor to it. The genetics or trigger bacteria or virus have been proposed as possible antigen to no to date no infection organism has been identified. So we don't know exactly what could be causing that. But right now we're looking at genetics. There's different stages, and they label it by early, moderate, severe, and terminal. So early, of course, no actual X-rays. Moderate is a slight bone or cartilage destruction. Again, this is rheumatoid arthritis. The inflammation response is going to be something that you're looking at. You do have cultural disparities here. It's more common in white and African Americans than in Hispanics. Hispanics and African Americans have higher incidence of severe arthritic joint pain. Some Native Americans have a higher incidence of rheumatoid arthritis than other ethnic groups in North America. Anglo-Saxon is more common, and disease presents systemic lupus, which we'll get to in a minute, is more severe among African Americans, Hispanic, and Asian than white women. So, all right. So again, with rheumatoid arthritis, it's a non-specific manifestation of fatigue, anorexia, weight loss. We're talking systemic at this point. It is an immune issue. So the you're going to have generalized stiffness may precede onset of arthritic complaints. Stiffness becomes more localized as the disease progresses. Limitation of motion and signs of inflammation, heat, swelling, and tenderness. Joint symptoms occur systematically and frequently after the small joints of the hands and the feet. So that's again your synovial joints. They affect nearly every system of the body. Rheumatoid arthritis develops in 20 to 30% of all patients. So the one of the things that you can look for is contraction, arthritic deformities. A lot of times the hands will become contracted like that. You're also going to see a rise in your erythropoietin sedimentation rate and C-reactive protein are indicators of active inflammation, and the increase in anti-nuclear antibodies and AIDS also seen in rheumatoid arthritis. Testing for anti-circular protein antibodies is another important diagnostic test. All right, so you're to reformulate you that that's part of your white blood cells that have to do with the inflammation process, but also reacting to allergens or reacting to antibodies, antigens specifically. X-rays are not specifically diagnostic for RA, so you can't use them as a sole space or sole diagnostic thing. And like I said, it is systemic, so you can experience this in mild pericarditis, which is issue with the sac on the outside, the myocarditis inside sac vascular lesions, kidney issues. You might have muscular issues, myositis, rheumatoid vasculitis, or vascular issues, peripheral edema, peripheral neuropathy, again related most likely to that edema and peripheral blood supply. You also can have carpal tunnel syndrome, uh, rheumatoid nodules. You can affect the lungs and the eyes. NSAIDs are prescribed for physical comfort. Physical therapy helps the patient maintain joint mobility and muscle strength. An individual treatment plan consists of the nature of the disease and joint function, age, gender, family, and social. So they're looking at many components when treating rheumatoid arthritis. Again, you're going to diagnose that through CBC, your erythrocyte sedimentation rate, which again is your white blood cell reaction. You're going to test positive for a rheumatoid factor, not all inclusive, but a good portion of them do have that. Anti-nuclear, antibody C-reactive protein X-ray studies involved in the joint, and then synovial fluid analysis. And again, that goes back to your erythrocentesis, the drain of synovial fluids. You're looking at nutrition and weight counseling, psychological, therapeutic exercise, rest, heat, cold, and your drugs, non-NSAID corticosteroids for anti-inflammatory, and reconstructive surgery or arthroplasty when necessary. The treatment of RA often involves MRAD therapy with methotrexate. The rapid anti-inflammatory effect of methotrexate reduces clinical symptoms in days to weeks. It has a lower toxicity than other drugs. So it's a methotrexate treatment. The methotrexate therapy requires frequent laboratory monitoring, so you really have to check that in the CBC and chemistry panel. It's going to be important to make sure you've got that. Corticosteroid therapy, again, with corticosteroids have such bad side effects. You have bone issues, you have moon face, you've got immunosuppression, corticosteroids. There's a lot of things you have to consider when you're treating that. Unwanted weight gain, simple weight loss programs are important. Corticosteroids also increase the appetite and increase high caloric intake. They might become distressed at Cushing's syndrome, including that's the moon face I just talked about, and fatty tissue in the trunk. So that's another possible factor to look at. Protection of the small joints for patient teachings is maintain joints in neutral position to minimize deformities. Ensure that you have plenty of movement, water. Use strong joints available for any task. Use your strongest for pushing or pulling or just active ADLs. Distribute weight over many joints increases instead of stressing just a few. So changing positions frequently, avoiding repetitious movement, and modifying chores to avoid stress on joints. Alright, so I'm really taking a break and make sure that, hey, I'm not always using this hand for this. Or I'm not always raising my hand above for this. Obviously there's going to be some psychological issues here, because especially when you have deformity or contracture, you're going to have loss of ADL, loss of function, and then if you're, on corticosteroids, you have weight gain, you have moon face, self-esteem and body image, fear of being disabled and deformity is some of the psychological factors that you need to look at for it. And that is rheumatoid arthritis. Now and again, rheumatoid arthritis is going to be different in that it's an immune issue, so it's going to affect systemically, and you can have a lot of contracture disability with that, and it's measured in states, whereas osteoarthritis is a little bit different, and osteoarthritis has had some type of trauma or repetitive use injuries or some type of endocrine issues. There's a cause for it. It's just a little bit complicated. The rheumatoid arthritis, again, you're looking kind of at genetic factors there, although there is some things that might indicate some type of infection. And surgery, when necessary, is one of the routes for rheumatoid arthritis. Another key factor is you won't see osteoarthritis bilaterally. rheumatoid arthritis, you might have it in the same joints. You want to try and do patient teaching that's going to minimize the stress on those joints for rheumatoid arthritis. And again, osteoarthritis, you're going to have that morning stiffness. Whereas rheumatoid arthritis, you might just hurt all the time. The systemic lupus, erythematosus, let me make sure I'm saying this right. Systemic lupus erythematosus, is a multi-system inflammatory. It's an autoimmune disease. It's affecting many organs of the body. It's genetic, hormone, environmental, and immune factors. So there's the SLE, or systemic lupus erythematosus. Typically affects the skin joints and the serous membranes. So you're going to see that in the pericardium a lot. You're also going to see it neurologically. Most of them occur in women in their childbearing years. So if you're looking at childbearing years in women as your SLE clients. Women are 10 times more likely than men to develop SLE. The hormones are known to play a big role in the etiology of SLE. Environmental factors can contribute to this: sun exposure, sunburns, infections, agents, severe or stimulants of hyperactivity. So environmental factors, sunburns, things like that. You're also looking at certain antibodies that might be in the blood, circulating immune complexes. The antibodies against DNA are deposited in the basement membrane of capillaries in the kidneys, heart, skin, brain, and joints. Complement is active and inflammation occurs. And again, you're going to see this in the integumentary, cardiopulmonary, urinary, musculoskeletal, reproductive. It's completely systemic. Gastrointestinal. You're going to see this in hematologic, if I can't say that. In the spleen, in the blood, and then neurological, which is stroke, seizures, psychosis, and cognitive impairment. It's got that butterfly rash, where it's a rash like this. And again, women are more likely to have this. The distinct criteria, patient history, physical exam, and laboratory findings. No specific test can diagnose SLE, but a variety of the abnormalities may be present. ANA is 97% of people have the disease, so that's that antibody that we talked about earlier. The anti-DNA, anti-neural, anticoagulant, anti-white blood cell, anti-red blood cell, anti-platelets, other antibodies. So these are all things that you could test for where we have some immune issues. NSAIDs are a primary source of intervention, and anti-malaria agents such as hydroxychloroquine and chloroquine are used to treat fatigue and moderate skin and joint problems. So that's kind of interesting. Your collaborative care for your systemic lupus erythematosus is making sure that NSAIDs, steroid-sparing drugs, anti-malarias, corticosteroids, again, you have your own issues there, immunosuppression drugs, because it is an immune problem. And you're going to diagnose this through urinalysis, X-ray, chest X-ray, EKG, and blood cell counts. All right. And again, with patient teaching in the lupus, you want to explain the disease process, name of drugs and side effects, pain management strategies, energy conservation, avoidance of physical and emotional stress, which can trigger episodes, avoidance of drying soaps, making sure they use an SPF over 15. And again, we're going faster. The myofascial pain syndrome is a chronic form of muscular pain characterized by musculoskeletal pain syndrome, most typically in the chest, neck, shoulder, hip, and lower back. The the temporomandibular joint, which is that joint that you move your jaw with. Regions of pain are often taunt bands of skeletal muscles, so that can be affected. Myofascial facial pain syndrome occurs more often in middle-aged adults and in women rather than men. Physical therapy is one treatment used for myofascial pain syndrome. A typical treatment is spray and stretch method, where they're icing and pulling and stretching at the same time. The local anesthetic, massage, biofeedback, ultrasound have been beneficial for some patients. And again, it's going to affect the chest, neck, shoulders, hips, and lower back, and that temporomandibular joint. The fibromyalgia is a chronic disorder characterized by widespread non-articulated musculoskeletal pain and fatigue with multiple tender points. People with fibromyalgia may also experience non-steroidal sleep, morning stiffness, irritable bowel syndrome, and anxiety. It's idiopathic, pathopsychological mechanisms of fibromyalgia. They're basically saying that it's in your head, but the fibromyalgia is a neuroendocrine issue, neurotransmitter, involves the CNS system. So the occurrences are healthy, young, middle-aged women, etiologies, infectious triggers, dysfunction. Clinical manifestation is musculoskeletal pain, knowledge, or just generally not feeling well, fatigue, chronic dysfusion, headache, sleep disorders, depression, anxiety. And the diagnosis, there's no definite laboratory test because they don't really know what's causing it. Therapy for this is antidepressant drugs, heart, massage, regular stretching, biofeedback, and stress management are really important here as well. Widespread burning pain. People might often complain of pain often results from stiff or painful neck. Fibromyalgia is sensitive, painful stimulus throughout the body. Memory lapses and a feeling of being overwhelmed. Migraine, headache, depression, and anxiety. Restless leg syndrome is also typical in fibromyalgia. Irritable bowel syndrome with manifestations. Alright, so again, there's not really a way to diagnose this. It's difficult to establish. Lack of knowledge about the disease makes it hard to test. Laboratory results in most cases serve to rule out other disorders. So this is one of those things where we're going to rule out everything and then call it fibromyalgia. So we're going to alternate, as most is alternate heat and cold packs, soothe and relax muscles, create blood circulation, gentle stretching to relieve muscle tension and spasm. Physical therapy, tolerated of course, and we want to limit the amount of sugar, caffeine, and alcohol beverages as they might increase muscle irritants. Vitamins and mineral supplements may help to combat stress and correct deficiency. So that is fibromyalgia. And that's going to sum us up for chapter 64, or as I was 65.